Hey everybody, let's talk about tracheostomy procedure steps. So I have my patient here, and obviously they're a little deoxygenated. They've got blue skin, but we're gonna go with this. The reason we have to do this is because they're not getting enough oxygen, right? So we're gonna feel with our patients, we're gonna find the end of the trachea, we're gonna find the sternal notch. Remember, the sternal notch is where the clavicles come and meet the sternum. We're going to mark our sternal notch. Okay, and then we're going to take 2 fingers and we're going to go up from the sternal notch 2 fingers, and we're going to mark this area here. This is generally 3 to 4 tracheal rings from the sternal notch. So this is about where we want to go. If we want to feel our tracheal rings, we can actually feel them through our patient. 1, 2, 3, and so we're about the same. Sorry, I missed my mark. My mark should be from top of the sternal notch. There we go. All right. So we've got our 2 fingers, 3 rings. I'm going to make my incision here. Remember, the skin is very thin. My skin will be thicker just because it's Coban. So we're going to make our incision. And we don't need a very big incision. Remember that our trachea tube's not that big, so we don't need a big incision. The first structure we encounter is the platysma muscle right here. Okay, so we're going to dissect the skin off of the platysma. Maybe. And then for the platysma, we're actually going to take our fingers and just separate those muscle fibers out. We honestly don't need to do much to separate the platysma. It's very thin, very small muscles, so if we get underneath there, we can actually do this pretty easily. So we'll go in there and we'll separate out the platysma muscle. Now at this point, we've got enough dissection that we can place our retractor that's going to be on the outside of our patient. So I've got a Wheatlander here. I can use my Wheatlander and hold my patient open. All right, we see the structure here. This may or may not be here. This is the thyroid, and I'm going to move my trachea back over where it needs to go. The thyroid may or may not be in your way. So just think about that you may encounter it. You may need to go right through the isthmus and cut into the thyroid and separate it. Fortunately, our thyroid is just a little bit above our trachea, so we don't actually have to do any surgery on the thyroid, which is nice. We can leave it alone, not poke it, make it angry. We are now going to have our assist grab onto the top of the trachea. Oh, maybe not, because maybe our trachea is not like real life. There we go. And pull up on that tracheal ring, and now surgeon's going to make their incision into the trachea. Remember, we have an ET tube in here. So we have an endotracheal tube that's supplying oxygen to the patient. So surgeon's going to try and be careful not to puncture that ET tube. That's why we're using a 15 blade instead of an 11 blade, is so that we don't poke too hard going into that trachea. There are 2 ways to make an incision. And for a tracheostomy, you can go this way and make an X into the trachea. That is for more short-term tracheal placements, such as our COVID-19 patients, patients that are going to get their trachea probably out within a month or 2. If it's a permanent trachea, we're actually going to cut out a square or a rectangle from our trachea. So it just depends on which kind of tracheotomy we're going to do. Dr. Perko is going to do an X, because right now, post-COVID, this is still the most common because we have our patients that come in with their tracheas. So you can see we have 4 flaps of trachea here. Now, at this point, we're going to take a tracheal spreader. I don't have a real tracheal spreader. This is a Vienna nasal speculum, but we're going to take this in here and we're going to spread this trachea a little bit like this. We're going to take our tracheostomy tube and obturator inside of it. We're going to put our tracheostomy tube inside of the trachea. Oops, and of course my tracheal spreader doesn't work because it's not a real tracheal spreader. And insert our tracheostomy tube into the trachea of the patient. At this point, we pull out our obturator. We give our patient some good suction. Make sure that everything's working good. We're going to slide this piece into our trachea. This is what anesthesia is going to hook their circuit to. So don't be surprised at this point in the procedure, anesthesia is going to reach over the drape and hook their non-sterile circuit to this. That is going to help the patient breathe. We can go ahead and come out with this retractor. We come out with our Wheatlander, maybe. We're going to blow up our balloon. So we have our 10 cc syringe already filled up with air. We stick it on there, we blow up our balloon. How do we know that our balloon is blown up inside the trachea? Because our balloon here blows up as well. So I can feel this and know that my trachea balloon is blown up down below. Last but not least, we are going to suture the tracheostomy tube to the patient. Most of our patients, if we're doing them in the operating room, are probably going to go to ICU afterwards, so we don't want this to come undone. So we're going to take a silk or a nylon and sew this on either side. We're going to leave nice long ties because we want our nurses in ICU to be able to cut this out if they need to. We don't want them searching for where the ties are. All right. I'll cut. Oh, maybe. I'll cut the C General doesn't have very sharp instruments today. Do the same on this side. Oops, sorry, did I grab you?
No.
And we'll cut. All right, and that is it for a tracheostomy. We are done.